Hello ladies and gentlemen, I am Dr. NIK NIKAM and welcome to Cardiology Lectures. And please do subscribe to our YouTube channel and bookmark our Cardiology Lecture playlist, which has more than 80 videos on cardiology topics. Today we are going to discuss one of the most fundamental aspects of cardiac function, which is based on what is known as the Frank-Starling Law. When I started the cardiology fellowship, the first thing we learned in physiology was Frank-Starling Law or Hart's Law, or how the heart functions based on some prerequisites. Frank-Starling was a professor in London University, and in 1918 he established the Frank-Starling Law. However, in 1904, Dr. Masterini from Italy had worked on the same concept, and Italian doctors call this particular law as Legge di Masterini. After spending more than 35 years in cardiology, I can tell you how much I appreciate the value of Frank-Starling Law, or the Frank-Starling mechanism, or the Frank-Starling curve, in understanding the pathophysiology of various cardiovascular conditions, but also enabling us to manage these patients in an outpatient setting, in a hospital setting, or even in an emergency room. So what I am going to do is explain the principle behind the Frank-Starling Law and how we can apply that principle at bedside when we are dealing with real patients. That's what I have been doing for 30 plus years, and that's what I'm going to show you, how we can apply the basic science, physics we study in medical schools or in fellowship and trainings can be applied in every instance when we are actually treating patients in various scenarios. Basically, the Frank-Starling Law says that if we increase the left ventricular volume, that stretches the left ventricle, and that increased volume and increased stretching of the ventricle forces the ventricle to contract more forcefully, thus increasing the output, which is the stroke volume. So that is the basic concept of Frank-Starling Law, or Frank-Starling mechanism, or Frank-Starling curve. That is a very simplistic explanation of how the heart functions. Frank-Starling said this law holds good when all other parameters are constant. I want to underscore the statement. The Frank-Starling Law applies when we increase the volume, that is the end diastolic volume. The stroke volume goes up when all other parameters are maintained constant. But you know, in reality, you cannot maintain all other parameters constant in a patient in varying conditions. As a matter of fact, all other parameters are going to be totally abnormal in a clinical situation, which makes it much more challenging to apply the Frank-Starling Law and mechanism. But nonetheless, the foundation is what is most important, because if we have the strong foundation, from there we can build our approach to managing patients with cardiovascular problems. So let's look at two particular scenarios, and here is a Frank-Starling curve. Now let's look at Frank-Starling Law or mechanism from a systolic heart failure point of view. And here is our normal curve. Here we have a normal Frank-Starling curve, and here we have a curve for a patient with heart failure. Let's say our normal volume is, heart volume is 125 ml, and we have a stroke volume of approximately 70 ml. And we go to like 175, something like that. Here the stroke volume goes up this much. But compare that to a patient with heart failure whose Frank-Starling curve is shifted to the right, almost like a flat curve. So what happens when you go from a volume of 125 to 175? The increase in cardiac output is very marginal and is still way below the normal cardiac output we see in a normal person. And any further increase is not going to get any benefit at all in terms of improving the stroke volume. What went wrong here? How do we fix this? So the Frank-Starling law works up to a certain point, but after that the response to an increase in volume may be counterproductive, or as a matter of fact it could be negative in terms of getting any benefits. In reality, that is exactly what we see in patients with systolic heart failure in advanced stages like stage 3 and 4. So how is Frank-Starling's law or mechanism going to help us to get a better understanding of what is happening here and how we can modify this to shift this curve from here to something like this? Let's look a little deeper. Here's an example which was the same one we saw. Let me take you to the anatomic structure of the heart in a normal person and in a patient with congestive heart. Then we're going to look at Frank-Starling's curve and see from what point to what point do we want to move this Frank-Starling curve in patients with heart failure. And finally, we're going to look at all the other parameters. Remember, I told you Frank-Starling mechanism law said the volume increase in the preload leads to stroke volume increase with contraction. That is, if we keep all other parameters constant. But I told you in reality and in patients with systolic heart failure, unfortunately, all other parameters are totally messed up. And we're going to look at each one of them and see how we can make a logical approach to still using Frank-Starling mechanism to improve one, patient's symptoms, number 2, improve patient's quality of life, number 3, minimize readmissions to the hospital, and number 4, hopefully improve longevity. All of those are going to be based on having a very basic understanding of Frank-Starling's mechanism. First of all, as you can see, here's a normal heart, the left ventricle, and here's a left ventricle in a patient with congestive heart failure. This tremendous increase in left ventricular volume. There is thinning of the left ventricular wall, as you can see here. The contractility of the left ventricle is depressed, which is reflected in the ejection fraction, which is low, like anywhere from 10 to 35%. There is left atrial enlargement, and there may be pulmonary congestion. That's why we have this one for a patient with a heart failure, which is quite flat compared to a person with normal heart. So here is the optimal preload, and anytime we increase a preload in a patient with congestive heart failure, we are going to have symptoms of congestion. Now, how are we going to move this patient who is having symptoms of congestive heart failure to an optimal condition where we have reduced preload or make the preload optimized to the given situation and in fact increase the stroke volume? As you can see, ideally we would like to increase the stroke volume from this point to this point, but we may be happy if we can get it to this point, but I tell you we'll be lucky if we can get it to this point, because in an extremely dilated flappy heart, improving the ejection fraction or the cardiac function is going to be the most challenging aspect of managing patients with the systolic heart failure. But let's look at all the different parameters that affect the final performance of the heart. Here are the same two diagrams, and our aim is to move this to the green line from a state of pulmonary congestion, heart failure, peripheral edema. We want to move this patient from this point to a much better point directed by the green arrow. In order to understand that, remember I told you all other parameters? So let's look at all other parameters which directly or indirectly affect the systolic performance of the left ventricle in a patient with congestive heart failure. The cardiac output is a product of stroke volume and heart rate. And of course, that's what we are talking about, stroke volume. But remember, stroke volume is related to the preload, which according to the Frank-Starling law is true. But the stroke volume is also based on the systemic vascular resistance. If there is increased resistance to the flow of blood, then there's going to be reduced left ventricular output. That's one thing we see in patients with chronic decompensated congestive type of heart failure, increased systemic vascular resistance. That's why we are going to use drugs that can decrease the systemic vascular resistance. Again, since these patients with congestive heart failure are already overloaded with preload, and on top of that, if they fail to take their medications or if they get into some medical condition, their preload can dramatically go up. And to address the preload problem, we use diuretics to reduce the preload so that we can reduce the pulmonary congestion. Now let's look at the second parameter, and that is the contractility. I already touched about contractility. The ejection fraction in a normal person is approximately 65 to 70%, but in a patient with advanced heart failure, the ejection fraction can vary from 10 to 35%, which is a dramatic drop in the amount of blood this ventricle is able to pump. So, is that something that we can use to improve the contractility of the left ventricle in patients with systolic heart failure? For short-term benefits, we can use medicines like digoxin or dobutamine to improve the contractility, assuming that we are dealing with a viable myocardium. In patients with congestive heart failure, again, we have excess circulating catecholamines. That's one of the reasons we use beta blockers, especially beta blockers which act on both alpha and beta receptors, such as carvedilol, that helps to improve not only the overall function of the heart, but also improve the forward cardiac output. If you are dealing with a patient with severe triple vessel disease who is chronically ischemic, doing a bypass surgery and improving their overall circulation over a period of time can improve their ejection fractions. I have seen patients with severe heart failure who have ejection fractions in the range of 25 to 30, who after triple bypass have improved their ejection fractions to 40 to 45, even 50% after 6 to 12 months. So that's an important thing to consider. In an acute situation, when we have a myocardial infarction, the most important thing we can do on a short-term basis is to recanalize the vessel, open up the artery, and minimize the myocardial damage so we preserve the left ventricular ejection fraction. Now let's look at another parameter we were talking about, and that is the heart rate. In patients with congestive heart failure, heart rate is an important factor that can mean symptom-free versus pulmonary edema. Take for example a patient with controlled heart rate who goes into atrial fibrillation with rapid ventricular response. They're going to end up in the emergency room with pulmonary congestion or pulmonary edema. So controlling heart rate is of paramount importance in patients with congestive heart failures. In order to do that, first of all, we need to know what the underlying problem is. If it's atrial fibrillation or atrial flutter, we need to not only control the ventricular rate, but also try to re-establish the sinus rhythm, because the atrial component in patients with congestive heart failure could be a major determining factor in improving the forward stroke volume. Especially patients who have bradycardia, putting in a pacemaker, preferably AB sequential pacemaker, can improve their overall cardiac function and thus improve their pulmonary congestion, reduce the preload, and improve the forward cardiac output. In patients with advanced heart failure and conduction disturbances, we may even consider biventricular pacing so that both ventricles, when they are synchronized, have a much better stroke volume compared to when they are not synchronized. So putting it all together, when we see a patient at bedside, in the emergency room or in the intensive care unit, we want to see what are the other parameters that we can really adjust besides preload to optimize the medical treatment, minimize their symptoms, and improve the quality of life. So I would like you to keep this list in your mind and go through this every time you see a patient with systolic heart failure and see how we can move the Frank-Starling curve in a patient with congestive heart failure from one of pulmonary congestion and reduced cardiac output to one of no pulmonary congestion, improved cardiac output, and improved quality of life. Now let's switch gears and look at another condition which is much more perplexing and much more interesting to deal with. That is the diastolic heart failure. How does the Frank-Starling law or mechanism help us to get a grip on the diastolic heart failure management? First of all, let's understand the pathophysiology of why patients go into diastolic heart failure, which is most commonly seen in patients with hypertension. Let's take a scenario. You're treating a patient with hypertension. His blood pressure is controlled and he has no cardiovascular symptoms and is moving merrily right along for years. But in the meantime, this patient has left ventricular hypertrophy. He has got a thick left ventricular wall. He has non-compliant left ventricle. He has a small cavity and diastolic dysfunction. That is, inability of this ventricle to stretch and relax. When you take this patient, now he is going through the holiday season, Thanksgiving, Christmas, stop taking his medications, stop taking his diuretics, and all of a sudden, right after Christmas, he is in the emergency room with acute pulmonary edema. How on earth can Frank-Starling curve or law or mechanism explain? In a patient who has an ejection fraction of 80%, left ventricular hypertrophy, who's doing fine, end up in the emergency room right after Christmas holidays. The Frank-Starling law helps us to understand that concept. First of all, what happened here? Let's say his blood pressure is 220 over 130. What has happened here? His systemic vascular resistance has shot through the roof. He forgot his diuretics. As a result, his preload has gone up. When you increase the preload and you increase the systemic vascular resistance at the same time, in a ventricle that is non-compliant, you are asking for trouble. Since the preload is increased, and because of increased afterload, the ventricle cannot empty, the only logical step is for it to go into the lungs and cause pulmonary congestion. They're going to acute pulmonary edema. But the good thing is patients with preserved systolic left ventricular function, hypertensive acute heart failure patients do respond very favorably to very delicate management of their hemodynamics. So this patient is in the hospital, you bring them into the intensive care unit. So what are the things that are going wrong with this patient? By looking at his structure, which we can determine by 2D echocardiography, and from your basic science physiology, you learned what Frank-Starling law means in a hyperdynamic heart. Now let's look at what are the other factors that are making this patient short of breath lying in the intensive care unit. We talked about the preload, which is increased. We talked about a significant increase in the systemic vascular resistance. And because of this acute shortness of breath, he can also have an excess circulating catecholamines. Vascularization is not a problem, contractility is not a problem, and myocardial ischemia is not a real problem unless there is an accompanying acute myocardial infarction or non-STEMI. Let's assume for a minute that we are dealing with pure hypertensive, uncontrolled hypertensive acute pulmonary edema. Because of acute shortness of breath, this patient may also have tachycardia, which can also add to the problem, because the faster the heart rate, the lesser the time available for left ventricular filling, which leads to more problem, which is pulmonary congestion. Occasionally we can have a slow rate because we pump them with a lot of beta blockers, but that may not be a real issue. If a patient with hypertension who has been moving merrily all along with all his holiday binge, let's say he goes into atrial fibrillation, now we got another problem, and that is atrial fibrillation with rapid ventricular response plus loss of atrial kick. When you lose atrial kick in a patient with non-compliant left ventricle, then the cardiac output is dramatically going to drop. In a non-compliant ventricle, 30 to 40% of the left ventricular output may be related to the atrial. See, all these things are explained by the Frank-Starling curve and all the other parameters which can have an effect on the Frank-Starling curve, and this is where the patient may end up. Instead of having no symptoms, the patient may have this pulmonary edema symptoms with maybe a slightly reduced cardiac output or ejection fraction. Now, how do we treat these patients? The most important thing is to reduce the preload, but at the same time, when you are trying to reduce the preload, you want to make sure you do not overdo this, because that can easily happen in patients with hypertensive heart failure. The most important thing is to use intravenous drugs to reduce the systolic blood pressure and thus reduce the systemic vascular resistance. We can use nitrite, nitrates, or nicardipine to reduce the blood pressure. If there are circulating catecholamines associated with the supraventricular tachycardia, we can use beta blockers, reinstitute the medications he was on to bring the heart rate down. We can also use ACE inhibitors or ARBs to reduce the systemic vascular resistance on a long-term basis. If the heart rate is fast, it makes sense to not only control the ventricular rate, we should make every attempt to get these patients into sinus rhythm, because atrial component in a non-compliant ventricle is of great importance in maintaining the stroke volume and cardiac output. So this is an overview of how the Frank-Starling mechanism or curve or law, which we learn in physiology, can apply to every patient, every scenario we deal with when we are talking about systolic or diastolic heart failure. Ladies and gentlemen, I hope this has been useful to you. Thank you so much for watching, and please do subscribe to our YouTube channel. We'll see you next time. I am Dr. NIK NIKAM.